Good afternoon. Welcome and thank you for joining us for today's webinar, Lessons Learned from the Management of Disability Due to Mental Illness, sponsored by Personalized Prescribing, Inc. Personalized Prescribing is a Canadian pharmacogenomics company with a focus on psychopharmacology. Their specially trained psychopharmacists work with patients both on disability or actively at work and their physicians to help optimize their antidepressant treatment. I'm Kristen Dougal, Director of Meetings and Events for Benefits and Pensions Monitor, and I will be your host today. Before we get started, I have a few housekeeping items to review. This is an example of the attendee control panel. You should see something similar on your own computer screen in the upper right-hand corner. Use the orange arrow to open and close your control panel. Use the audio pane to select your preferred audio. Choose computer audio to use your computer microphone and speakers, or choose the phone call option to use your telephone and dial in using the information provided. If you have questions for today's presenter, please type them into the question pane of the control panel. You can submit them at any time during today's session. We will be collecting them and addressing them during the audience Q&A portion at the end of the webinar. Use the handouts pane to download the available documents. You do have access to download the documents, including the speaker presentation, anytime before the webinar ends. Please note that all attendees are in listen-only mode as we'll be recording this webinar. It will be available to view on our website in the next few days. To begin, let me introduce you to our presenter. We have Mark Faiz, CEO at Personalized Prescribing, Inc. So let's jump right in. Over to you, Mark.
Thank you, Kristen. Thank you, ladies and gentlemen, for attending this afternoon. It's a pleasure to be making the presentation. In a little bit of technology, I hope everybody's now listening to me and can see me.
Yes.
So again, thank you, ladies and gentlemen. I'm going to get right into it. When I'm talking about disability this afternoon, I mean mental illness disability. Let's understand that. This is not about any other type of disability. And I'm going to try and set the stage for you by talking a little bit about some things that we have found out during our work for the last 4 years. Before I do that, I'm going to tell you a little bit about my team. We're a team of psychopharmacists, and over the last 4 years, we've worked successfully with insurance and disability management companies and helped their employees get back to work. Our pharmacists are assisted by pharmacogenomics. But over and above that, we also offer our services to actively at work employees through some insurance companies and some plan sponsors. In setting the stage, let me talk a little bit about, what causes mental illness. Let's go back to the beginning. It starts at birth. We are all born with genetic variations that could make us predisposed to mental dysregulation. But that alone does not cause the disability, the mental illness. That only is a predisposition. What causes the mental illness is a trigger. A trigger is needed, and usually the most prevalent trigger out there is a chronic stress of some kind. Although some trauma and injury and some diseases could cause the dysregulation, but you really need both the dysregulation, the predisposition, as well as the trigger for the dysregulation in the brain to occur, which leads to mental illness. Having said that, that is the cause of mental illness. That is not the cause of disability, however. So what causes disability? One word: psychotropic medication. Psychotropic medication is a very challenging medication. Unlike any other medication out there, psychotropic medications fail almost 50% of the time. And while they're failing or not, there is adverse drug reactions sometimes can be so bad that the person, in spite of feeling better on the medication, will drop the medication because it's causing such severe side effects. The reason for this is simple. It's the brain. We're talking about the most complex organ in the body by a long, long shot. Now, there's other reasons why mental illness medication eventually could cause to mental illness disability. The reason is, unfortunately, antidepressants do not work like other medication. They don't work right away. They take 6 to 8 weeks to become effective. They start at low dose, and then we titrate them, or the pharmacist and doctors will tell you, increase the dose gently over the next 2 or 3 weeks. And in the meantime, you're really not feeling any difference. But you still might be getting these side effects, which could make you quit the drug a little bit too soon. So when you combine these two together, we got a problem. Now, managing mental illness disability is a challenging thing. And part of the reason is, apart from the fact that the science is really simply not advanced as other conditions. With other conditions, we can actually diagnose them properly through a blood test, a urine test, through a biopsy, through something, and we can take it to the lab and we can understand, okay, we now understand what's going on. Unfortunately, with the brain, you just can't take a biopsy. You can't take a piece of the brain and put it under a microscope. Now, the other thing when it comes to mental illness disability management, there is no predictable or systematic process for rehabilitation. So our experience with disability case managers is that they're kind of frozen. They get a doctor's note saying, yes, the patient is disabled, and then, okay, we believe you, but then we're not sure. I'm being a case manager and how they think. When do I start the rehabilitation process? And how do I start the rehabilitation process? Now, before I go much further here, let me just make it quite clear. We're talking about mental illness disability. And therefore, when I'm referring to mental illness in this context, I'm actually talking about serious mental dysregulation. We all feel a little bit of depression from time to time because of things that are happening to us and so on. This is not what I'm talking about. I'm talking about a serious situation that has now progressed enough that the patient have said, I can't work. Now, in doing all that, I've just finished setting the stage, and now I'm going to show you some of the lessons that we've learned, and that might shed some light as to, who are these people that become actually depressed and then they go into disability. The one lesson that we learned, which really is astonishing, it astonished me when I first saw it 2 or 3 years ago. It's almost 100% of our patients had a very high genetic variation score. Now, what is a genetic variation score? Well, imagine, so we're testing in our lab for a whole bunch of genes to inform our pharmacist how the patient will respond to 3 aspects of the drugs. The first aspect is drug clearance. The second aspect, clearance from the blood, from the brain. I'm sorry, from the blood and the brain. But then the blood, the drug has to enter the brain. And right there at the entry to the brain, there's what we call the blood-brain barrier, which is trying to protect the brain and perceives drugs as if you like, invaders into the brain. And so it's always clearing the drug out of the brain. And finally, we need to know a little bit about the brain receptors that are the targets of the drugs. So go back to the genetic variation scores. What we've done is we've actually, we noticed at first, oh my God, these patients have so many variations across the board. One in here in the clearance, one in the brain barrier, and 6 in the brain receptors. And then the next one the same way, and so on. So we developed the score from 0 to 20. And 0 meaning you have hardly any variations in the specific list of genes that we're trying to monitor, right? So there are no genes outside psychotropic medications. And we then, so 0 is for a person that has no variations whatsoever, 20 for a person that has a lot of variations. And just to give you a good idea, we have a little analysis that we did from the Genome 1000 project, which is basically a statistical project that looks at how many people from a population that's mostly Caucasians, but some Asians and African Americans mixed in with it. And they basically look at, for this particular gene, how many people are likely to have the variations. And this gives you a fairly nice idea. So what you're looking at here is that, out of 1,000 people, this is the number of people, and the x-axis is the number of variations. So people that have 2 variations are only 50 out of 1,000. People that have 4 variations are 150. And people that have 10 variations are only like 60, 70 or sorry, 50. So the genetic variation score, ladies and gentlemen, are, okay, and now I'm back to here. What we noticed is that almost every single patient that we saw, and we continue to see, have a very high genetic variation score, means they sit here in this area of the graph. Most of us are in this area of the graph. And if you like, these people are resilient. They have very few genetic variation scores. And as a result, they respond to medication much faster. Now, let me go to the next lesson. The next lesson that we learned is that we found out that, my God, almost 30% of our disability patients were treatment resistant. Now, let me explain what that means. Treatment resistance does not mean they have no hope. No, it just means there's not one medication that can enter their maze of a brain and find the target easily. They somehow have all kinds of problems, which dovetails really well with the previous graph here. These are the treatment resistance are people here, right? Now, it doesn't mean that there's no help for these people, but our pharmacist tries to use more than one medication to fix whatever the problem might be within their brain. Now, these two together actually will give you an idea that, these are the people that actually will eventually, if are faced with mental illness, could eventually end up with disability because they're having problems finding the right medication. When a patient who's mentally ill finds the right medication, You never hear about it. Very quietly, they're now in control, they're managing their illness, and they're fine. The third lesson, ladies and gentlemen, has nothing to do with psychotropy or science or anything. These are, now remember us, we are a bunch of pharmacists, and we're really not disability managers. So we're out there sort of helping these disability managers. And what we find is a really interesting scope, if you like, of patients that are either very motivated and they want to come back to work, and others that are less motivated, and others are least motivated. And what we find is that patients that are actively at work, which indicates that their mental illness is fairly recent, they're still struggling with it, they're trying to deal with it, they went on one medication, it's not quite working well, but they're still at work, and they then claim our service through their insurance company or plan sponsor. And we find that these employees are much easier to work with. They respond to our pharmacists very fast. They're eager to listen to our results. They ask questions. They want to get better. They go back to their doctors and they insist on a doctor's appointment as fast as possible. They want to change their medication, and they really do begin to feel much better. With disability, there's a wide array. Almost a third of them are also quite motivated, and they really want to get with it. And a third that are kind of difficult to work with. They're not motivated, but they eventually come around to it after our pharmacists reach out to them once or twice. And then there's another third, disability patients, that basically it's surprised us in that basically they get referred to us by their disability case manager, who's willing to pay for our service, and yet they agree to do the test. Now, if they somehow disagree to do the test, we stop right there, thank you very much, and we move on. But they agree to do the test. But then they might not return their sample fast enough, and they might sit on it for a month. And then when we get the result and we reach out to them to talk to them, they respond after a week or two or three or never. I mean, really difficult people to deal with. The one thing that we found out is generally, the faster you get somebody after they get the mental illness that has become serious now, the easier it is to keep them at work or return them to work. If you let them descend into long-term disability, oh my God, we got a problem. Because the problem is not that we can't help them. We maybe can help some of them. It's their motivation. Anyway, let's move on. So having said all that, can we draw some conclusions from all this? I've talked about genetic variation scores, and I've talked about some of these people are the treatment resistance people. We talked about the fact that we can identify the main reason for why people actually become disabled to do mental illness. It's the medication. And the main reason why the medication failed is the genetic variation score. And that's why they would need some kind of a psychopharmacist to help them, assisted with pharmacogenomics. And two questions I'd like to ask. Can we somehow identify employees that may become candidates for disability due to mental illness? The answer is yes. But nobody's going to do that. Let's be honest. You're not going to require all your employees to submit to a genetic test to find out whether you're predisposed to having a high genetic variation score or any of like that. And then the Genetic Non-Discrimination Act sort of says, wait a minute, you cannot force anybody to do a genetic test in return for anything. Forget it. It must be voluntary. Now, on the other hand, can we prevent disability from occurring? And this is an absolute yes, you know. And you do that by, it's obvious to me anyway. You do that by making sure that when they do hit the wall with regards to medication failure in mental illness, you're there to provide them a pharmacogenomic service that can put them on the right medication very quickly. And if they do, employees on the right antidepressants will not go into disability. And obviously, grab them before they get there. Now, I'm coming now to the end of this. I wish I have a lot more time. For pharmacogenomics to be effective, you really do need many different steps. You cannot just do a test looking at how the medication clears the blood. That's not enough. A lot of people do have this, our competitors, and they do a very good job with it, but then they don't go further, deeper. You need to actually test for the blood-brain barrier genes to actually ensure that the drug will actually cross the brain-blood barrier, stays in the brain enough to do its action before it gets ejected. And then the test must have the drug targets, the brain receptors in the brain, whether they're turned on, overexpression, underexpression, and finally, believe me, without a proper pharmacist looking at the results and understanding what they really mean, and then boiling down into a simple little recommendation, one-page thing to the doctor, doctors are not going to take it seriously. Doctors, unfortunately, just simply don't have the time to go into too much of this. Our company, ladies and gentlemen, and I promise you, this is the only sales thing I'll throw at you, is we tick all these boxes. Very quickly, I'm going to say, look, honestly, our results are exceptional. I've left a link here for Google reviews. We've got quite a few of them. Every single one of them is a 5-star. And finally, I'm going to throw a little pitch for our sequel webinar in October. It's exactly a month after, or October 12th. We're going to talk about a very specific case of a patient, and we're going to take you through that patient's journey from before he came to us, because he shared with us the journey and what happened and what got to his mental illness, and then how our pharmacist brought him back to work. That's all I have to say, ladies and gentlemen. Back to you, Kristen.
Perfect. Thank you so much, Mark. I really appreciate you taking the time to share your knowledge and insights with us today. I also want to thank our sponsor, Personalized Prescribing Inc., for their hard work and support leading up to today's webinar. So we will now open it up to live questions from the audience. We do have a lot coming in, and we only have about 5 minutes, so we'll try to get to as many as we can. So, Mark, the first question is, do you know what is the successful return to work rate for patients who completed the PGX test?
Yes, I can, but I'm going to preface this by saying, as long as the patient responds to our pharmacist and works with us as a team, and that requires the case manager to actually be back on top of the patient saying, did you respond to them? Did you do it? Did you return the sample or whatever? 60% of these people we find eventually do return to work.
Excellent. And aside from pharmacogenetic testing, who, in your opinion, may be at fault for a lack of proper drug prescribing?
Honestly, I can't blame anybody. Look, the science is just not real. It's not there. And finally, diagnosis is so weak. I mean, look, honestly, how do you then treat somebody? Mental illness is not one illness. there's depression, there's anxiety, there is this, there's that, OCD, there is PTSD, there's 60, 70 different types of dysregulation. And it is a real disease. It's a dysregulation of a neurotransmitter in the brain. So I'm not blaming anybody. Honestly, doctors, they don't know where to start. I tell you what they do. They have what they call a list that they say, try this one first. If it doesn't work, go to this one. So honestly, without pharmacogenomics, and pharmacogenomics, it's not it's not a silver bullet. We struggle sometimes with some tough cases, but it does help a hell of a lot. Sorry, I don't want to take too much on one question. Can't
Thank you. And in your experience, what percentage of what is seen as a mental health disability is actually a DSM-5 diagnosis made and followed using the most up-to-date, objective, and validated methods?
Okay, I don't know if I'm qualified enough to talk here, because the DSM is something that psychiatrists or doctors will measure, talking to their patients, and we don't get involved in that. We ask some questionnaires earlier on, but I can tell you, without going into DSM and exacts and so on, I will tell you, most of the people that come to us as a result of disability, these are disability patients. They really are got problems. And we know they've got a lot. 92% of the time, we recommend different medication. That answers the question.
Perfect. And at the start of your talk, you indicated that mental illness starts at birth with genetics. Can mental illness be avoided, or are these people just doomed?
Yes, it can be avoided. The way to avoid it is to number one, we need an education. We need people to understand that I might be vulnerable, right? Not for it. But the next thing is, when there is mental illness on its own, the genetics don't cause it on its own. There has to be a dysregulation, and that's caused by a chronic stress. 70-80% of the time, it's a chronic stress that actually causes excitatory systems in the brain to start working, which then starts to dysregulate some of the neurotransmission systems, which then leads to mental illness. So number one, if a patient knows, and we are working on genetic tests that will actually talk to us about predisposition. We're not ready there. It's going to be another few months. But if a person actually, if a kid knows that, I'm predisposed to mental illness, that kid should not apply for a job as a firefighter, because you're asking for trouble, right? Because that person is going to end up in PTSD.
Great. And I think we have time to kind of ask one more question. How do you think the quality of diagnosis can be improved?
Well, there is one huge effort scientifically right now on what they call brain imaging or neuroimaging. So what they're looking at, the scientists, believe it or not, let me just tell you something. This is going to shock some of you, is that when we say this person is depressed, what is in fact happening is this person is losing neurons in the brain and is unable to generate new neurons. So the brain begins to shrink. And certain areas of the brain shrink more than others. So neuroimaging now is looking at a way to diagnose, but what we are going to do and what we're hoping to do soon to introduce genetic tests that can tell us where from the genes and the weakness in the genes in the brain, where the weaknesses are such that there is dysregulation. But then this is not going to be an exact science, nor is neuroimaging. It's just one step along the way.
Thank you so much, Mark. Unfortunately, that is all the time that we have for today. If your question was not answered, I will be passing them along to the speaker and sponsor company, and someone will follow up with you directly. I want to give a big thank you to everyone for joining us today, and of course, Mark Faiz and Personalized Prescribing Inc. We hope that you leave us having learned some new and valuable information. At the end of today's webinar, you will be prompted to answer a short survey. We encourage you to give your honest feedback to help us with future planning. Have a wonderful rest of your day, and please stay safe, everyone. Thanks, Mark.
Thank you.